Good. All right, everyone should have access to the notes. Those of you like to review it later, that's fine, but it is handy to have. I did click a few in here. If you added a few links to this, which is just basically some readings on anatomy review. If you're the type of person who wants to read a article that's more in depth, there's plenty out there written. And I definitely gave you some nice some easy articles to digest to link in the pre-course prep. I know some of you are, avid readers and want to have all the information you can. Other of you prefer to kind of rely on the tutorial portion of it first and then maybe go back and review. I'm good with either method. Joey, tell me a little bit about the shape of the AO joint. What in your mind, describe to me the AO joint.
So I think of it as you have like tennis balls that come down onto like a cup, essentially. So like the occipital condyles are like ball shaped,
Mhm.
and then they come back onto the like a I guess I can show you with my hand. I don't know if you can see this. Can you see me?
Really?
So like I think of it like this. So if you have like a ball and then it's coming here. So the convex on the concave is how it moves, and it's responsible for nodding.
Yeah, I mean, 360 view, yeah, great way to look at how this joint moves because the two joints, certainly work together. We're gonna look at them a little closer in isolation. But as you even see, there's one diagram here on the upper right-hand corner. That's exactly how they have it kind of represented in this scheme as the way it's set up. And in the description of the particular facets, you can see that the occipital condyles are oriented slightly medial and lateral, forming a bit of that cup. And, then the C1 facets, concave and superior medial, forming that bowl shape that ball joint sits in, allowing to do it. And because of the joint shape, grossly, the largest motions you're going to have are flexion and extension, with some side flexion and rotary components. And you'll learn to kind of evaluate them because those components are kind of sometimes where we can get jammed up. So thinking about this, I mean, this is kind of, we think about a lot is that forward head position. And Eric, by all means, chime in little details that'll be important in here. All right, Austin, describe to me the motion that occurs at this joint when I am, well, let's go forward head posture. What position is this joint likely to be in if I'm in a forward head posture?
You protrude through the cervical spine, then this joint is going to extend.
Okay. So can you describe to me the glide of this joint?
So, yeah, you're going to have a posterior rock and an anterior
Mhm.
glide because it's kind of, I look at it like a rocking chair. And it's gonna rock, but it runs out of room, so it's gonna slip forward a little bit.
Okay. I'm on the posterior one here. Sorry. There we go. Like, why doesn't this work? And that forward head posture is going to be there. Yep. Your glide. So let's think about what muscles are likely to be hypertonic and inhibited in this posture, Alston.
Um, I'm gonna say probably our posterior occipital muscles are probably going to um I'm just kind of guessing right now, but I think they're going to
Yeah.
probably maybe limit some anterior translation.
You're going to limit anterior translation? Describe to me what
Um,
muscles your patient comes in the clinic and they have this posture. From a gross standpoint, what are you expecting to happen? You mentioned posteriorly. What's happening most likely in these muscles posteriorly?
they're gonna shorten because they're gonna be relaxed more. The posterior muscles are gonna be shortened because they're relaxed, or they're not gonna be on stretch. It's gonna be more anterior muscles stretched.
So this is more of a passive position for them in the posterior muscles within we have the forward head posture. That's a forward glide posture, but it's the best one I had. It's
Actually,
kind of funny looking, so I
yeah,
include it.
I'm talking in circles, but as we're thinking through it, they're actually probably being active to pull the head up,
Mhm.
pull the upper levels and into extension so that you can keep your eyes forward.
Mhm.
Um, so they're going to be contracting. Um,
Yeah, these muscles will tend to be kind of your facilitated muscle groups. And your splenius muscles, they talk about semispinalis, but I think generally talk about semispinalis capitis operates differently than semispinalis cervicis in this, but so it'd be more semispinalis capitis by being hypertonic with your superior obliques and your deep things. So Kyle, what then happens basically? What do we expect to see in the front? What muscles stabilize the occiput in the front of the neck anteriorly? And what do you expect the in general facilitation or inhibition pattern of the anterior neck muscles to be?
Anterior neck muscles are your deep neck flexors.
Yeah,
So
deep neck flexors.
I'm sorry.
Yeah,
Okay.
deep neck flexors.
Um, and then they'll be elongated. They will be inhibited because they're just hanging out in that position.
Yeah, so chicken or the egg, are these muscles inhibited from the position or are they going to actually be weak? Because I mean, we've all seen the deep neck flexor exercises and endurance-based exercises that occur. What do you think happens? Let's say these muscles aren't weak. What happens to these muscles when I'm in this forward headed or problem? Let's say I'm stuck in this anterior position.
Okay. So what happens to them when you're
Yeah.
stuck in?
Think about it. If I'm in this forward head position and I get maybe say a capsular restriction that holds me into this position, what's going to likely be the impact on the deep neck flexors?
Well, it sounds like they may not necessarily have been weak in the first place, but if you have a capsular restriction, you wouldn't be performing much atlanto-occipital flexion, so you'll
Mhm.
eventually get weak.
Yeah, it can eventually get weak. Or you get many times what you have is if you're always in this pattern, you can think now about inhibition. Like, is it more that these muscles, in a sense, get turned off
Mm-hmm.
as much as they are weak? And that portion of it, I don't think is written about or talked about as much. You'll see it in some of the literature where they'll see that, okay, you can manipulate the upper craniovertebral region, and you'll see that this muscle tone will improve right after the manipulation. I think in some studies it tends to go back down immediately, shortly afterward. But Eric, thoughts on this mechanism?
Well, and this is exactly what we talked about previously with some of Gwendolyn Jull's research and such on the transverse abdominis and things of that sort of nature. Their suggestion is that the pain that you develop in your lumbar spine is because the transverse abdominis is not firing properly, right? The question then is that I always have had is, well, is it not firing properly because of the pain, right? So it's the same situation that we have here. Are we dealing with inhibition that creates the positional dysfunction or the movement dysfunction, or is it the movement dysfunction that then creates the inhibition, right? And I would tend to say it's the latter, that the movement dysfunction is what's creating a lot of the inhibitory problems. Personally, I think that way just because I look at muscles as more of a reactive structure, as opposed to something that's going to be just making decisions on their own, right? Their activity and their function is determined a lot of times, especially in this type of muscle that's more postural, that's more static. Um, these things are designed to react to different receptors that are in various structures. So joint capsules, ligaments, all of these sort of things, I think, are the things that tend to facilitate these muscles and make these muscles, contract and turn on and do their jobs. When we lose some of that feedback mechanism, I think that's when these things tend to become dysfunctional. And we see that very significantly in the multifidi, particularly in the lumbar spine, because they're bigger muscles down there and we can actually see them much better. Where we know that they have a certain reactivity to the tension in the annular fibers. There's receptors within the annular fibers that are supposed to reflexively turn on those multifidi muscles. And that's been proven experimentally, not just experimentally, but surgically, where it was actually reported that when they put tension, put pressure onto the disc during surgical procedures, they could see the muscle fibers contracting in those multifidi. So I think that that process that can kind of be extrapolated toward these type of muscles as well. So that's my thought process on it, is that the positional dysfunction, the movement restrictions or movement dysfunctions is what tends to cause these inhibitory processes and affect the resting motor tone, or with kind of that length tension relationship that we'll have anteriorly to posteriorly, where we'll have that inhibition anteriorly and hypertonicity posteriorly. But I don't think there's anything definitive that suggests one way or the other. That's just the way I look at it, because when I think about what am I going to do to treat these things, if I have movement dysfunction, I have a stiff OA joint, say on one side, on the right side, maybe from a, old traumatic arthritis or something like that, I can work on fixing that sort of thing. And if I do that, I may help to improve some of the motor tone, some of that coordination, some of that length tension relationship that we have to have front to back. Versus if I'm just going to have them sit there trying to do chin tucks and all these deep neck flexor exercises and things of that sort of nature, it makes me feel like I'm beating my head against the wall. Because I used to do that sort of thing. I think a lot of us have done that, where the people come in with neck pain. It's okay, here we go. We're going to do this neck stabilization routine. And we don't think of the biomechanics as much, especially as younger therapists. That's just one of the things that happens. We get a little nervous about treating upper cervical dysfunctions, right? And so we try and work on the exercise component because it seems safe. But it doesn't yield the same type of results. And I can speak to that because I've been the guy that did that, went through that, just did the exercise stuff early on in my career, finally learned how to do these things and started seeing significant improvement in the results that I was getting in clinic when I started doing the more hands-on stuff that's associated with correcting movement restrictions, movement dysfunctions, and then working on the exercise components and the movement retraining and things of that sort of nature. So that's my thought. I think the movement stuff, the joint stuff usually comes first. But there's probably situations where both come concurrently, as far as trauma, right? So if we get in a rear end MVA, we get trauma and damage to the muscular system itself, along with some of the articular structures. And so you have to kind of think of that, based off of how did these things come on in the first place. But that's my thoughts. I tend to think articular stuff tends to happen first.
Yeah, my perspective as well is like I want to know what's going on in the articular system so I can understand kind of where to go next. If I don't understand that, okay, I have an articular restriction driving this, then you're right. The exercises, the movement-based stuff, it may be a pain modulatory technique at best, and then I expect it all to come back shortly thereafter. So it's like, okay, I don't know the biomechanics of these joints. Go in needle, I inhibit the pain for a little bit, but the joint biomechanics are off. So within 12 to 36 hours, there's a regression to the familiar again, and they come right back to where they were. Or what I want to be able to do if they do a restriction here in the upper craniovertebral region is to clear that first, address it, get the system to rebalance and get the head balanced and get these joints recentered and then normalize that muscle tone. Then I can retrain deep neck flexors, or what I more think of as just important is maybe inhibiting some of the extensors, which are driving it. So we often think of, hey, I want to strengthen deep neck flexors, but maybe where is that balance in between inhibition and facilitation of the upper region? So I tend to kind of play those two off of each other. Because if these muscles are just been ingrained to be hypertonic and hold me there, then you're not gonna have any luck with retraining deep neck flexors until you balance that portion of it out.
Well, and you have to get to it before you start getting some of the more global muscles involved with this stuff too, because the SCM can be one of the ones that'll be most consistent with holding you into these sort of positions. It should be crossing the neck at a certain level where the deep neck, the anterior suboccipital musculature will nod the chin. And then at that point, when that happens, this SCM becomes a neck flexor. But if it actually crosses the neck a little bit lower, what ends up happening is it ends up extending the CV region and then pulling the head forward as it shortens. So when that happens and that facilitatory mechanism starts to kick in, it'll also do the same thing to the upper trap as well. Then we're in a much deeper hole to try and dig ourselves out of, because It actually, because when you think of the innervation of the SCM and the upper trap, right? These are accessory cranial nerve muscles. At that point, we're looking at more of a facilitatory influence, what we would consider a segmental facilitatory influence that's starting to affect the head and the cranial nerve system. And that's something that we'll talk about later on. But that's much more difficult to get rid of once that stuff starts to kick in.
Yeah, isn't it every research study you may have ever read is okay, down ramp sternocleidomastoid tone, facilitate deep neck flexor tone,
Yeah.
you know, and getting into a question asked on the board, it's the same premise as we look at that balance between these two, where you look at insufficiency of that. They look at that altered axis. One of the things you look to do is can that person get eccentric control? Because once I get in here, my sternocleidomastoid should be in a normal motion, kind of down ramping, and I'm relying on my deep neck flexors with that extension motion to control it. And that's one of the eccentric exercises for it. Whereas when the sternocleidomastoid does it, you tend to get a jutting forward and the head balances that way. So the balance of the sternocleidomastoid, as Eric alluded to, is important. And you do see that exact mechanism. It's basically a hallmark in the literature you're reading or not reading. Boy, it's so hard not to call him Patrick. I'm telling you, it is painful not to call him Patrick. So we'll have to go with Jess. Jess, we kind of talked about this. Think about deflection and nodding here. The easiest way to get through this is kind of reading the notes that are in front of you. So a little bit easier. We have the mechanism that's kind of producing this. We have this cyclical. We have an anterior roll and a posterior glide of these joints as we do this. And again, when we get our hands on heads, what I want you to be able to do is to, in clinic, get your hands on the head and think of the head like the ball, just like Joey talked about. And I want to have that ball, basically, the tennis ball, be able to spin. And you're going to be able to kind of get a sense of what these joints are doing and talk through it in your mind. During the lab session, we'll work on isolating the left and right joints using some side bend rotation components to it. But here, again, think about this. What muscles have to lengthen, Jess, to allow me to go into a craniovertebral flexion?
Your cervical extensors, so your your traps, your this is so, I don't like talking.
It's hard, isn't it?
I really hate this.
Yeah, it's stressful. But good, that only excites me more. So yeah, let me keep pressing you.
That's great. I'm so happy. Your
I would do this. I would work superficial to deep. And so upper trap is a perfect one. What's under the upper trap?
Your cervical paraspinals. They're those, yes, those.
Okay, let's go a little bit there. Let's go levator scapulae would be the next one in there. And there can be different patterns based on the scapula. So you have to take the scapula into account in this, which we'll do later on. So you have levator scapulae. How could levator scapulae, could it impact this joint? Does it have an attachment that high?
I think it's at the transverse processes of the higher upper cervicals.
Yeah, it'll attach to the transverse process. So you can have some facilitatory influence there as well, which can impact C1, C2. Okay, let's get a little more specific. Let's go a little other superficial layer, be splenius capitis, which kind of attaches like down below from T3 to transverse spinous process, T3 to T6, running more laterally up to the side of the skull, or up over here like a V. And that is a muscle which is typically facilitated in somebody with a forward head posture. So that's a muscle that in this position, as we try to get to this position, say as our treatment, we want to inhibit. What is it? What are two other cranial extensors that have to reset if we're going from forward head posture to craniovertebral flexion, or to inhibit to allow this to happen? Okay, if you get really nervous, just read what's in front of you.
Your longus capitis and rectus capitis.
Yeah, you have the rectus capitis muscles. You have the semispinalis capitis as well. It's the upper portion attaches there, that forward head position. It's going to pull me there. So I need to get lengthening and inhibition of those. So anything that's going to kind of bring me here. We want to kind of look at that for that nodding motion. So longest cap is rectus cap is produced by. But if I were to go motion is limited by, I don't have it in here. I thought I did. I would be looking at those upper cervical muscles, splenius capitis, semispinalis capitis, rectus capitis posterior major, rectus capitis posterior minor, as being muscles up in there that'll influence that position. Generally when you're doing rehabilitative exercises with this, have you ever used quadruped exercises for this, Jess? Quadruped exercises with craniovertebral flexion or rotation?
I have.
You have good, and those exercises are nice, and they very well popularized by the Australians. And that really, when you're isolating there, they like those quadruped exercises. Because when I do craniovertebral flexion, I take this diagram here and I turn it on its side, which I can't do right now. You basically, it down ramps the facilitation of upper trap levator. And what you're trying to also do is down ramp the splenius capitis and semispinalis capitis as we do this flexion, and it tries to upregulate some of the mid-cervical muscles. So those mid-cervical muscles, which are generally kind of with these forehead postures, not doing their functional job, we want to inhibit the cranial extensors and facilitate mid-cervical spine. So we'll get the quadruped exercises into the program as well, just some of the other exercises that you do for it. But those are some of the things that we want to consider when we're looking at this. We think about with this, which muscle may be facilitated and has to lengthen, which muscle may be inhibited that I want to have more active. And the cool part about that, Jess, is it's all the muscles we've been taught. Do you ever do any suboccipital release, Jess?
I do.
You do?
I do.
How does that usually feel to you? Does that usually feel super successful and pretty gratifying?
It makes the patient feel great. I do that a lot when patients have a forehead posture and like cervicogenic headaches. I try not to do it too often because I'm just sitting there and I feel like it's almost like not a waste of time, but not very efficient of my time.
Yeah, I always find it's less efficient my time. Eric, do you spend hours doing suboccipital releases?
No.
Yeah.
Hardly ever. I mean, sometimes you have to do it in order to get to.
Mhm.
I mean, this is a bit further down the line from where you guys are at with this right now. But if I'm looking at, performing some sort of technique on the OA joint or the AA joint of some kind, and I can't get to the barrier, can't find the articular barrier because I'm running into an elastic end feel, a muscular end feel, then I don't have a choice. I have to do something to down ramp it, whether that's needling or some sort of deep pressure release or, some sort of exercise thing to get this thing to the point where I can actually engage the barrier that I need to improve. So sometimes you have to do it. Sometimes you don't really get much of a choice, but I try and avoid doing it too much. Number one, it's not great for my hands at this stage of my life, but yeah, try and avoid doing. I try and avoid doing too much muscle release stuff in general, just because it's like I said, I think muscles are more of a reactive structure, and I'll get longer relief, more permanent changes if I can fix the articular thing rather than working just on the muscle.
Mhm. And so, Paul, talk to me if we're thinking about this. If I wanted to inhibit the suboccipitals and the craniovertebral extensor muscles, what would be one cue I could give them using the eyes to do this?
So trying to inhibit the tight or hypertonic posterior muscles
Yep.
by cueing the eyes, like the eyesight.
Yeah, right. Yeah, and you can thank Patrick for this because he had asked me to treat you this way. So I'm
Thanks,
just
Patrick.
following orders.
Let me think. So if you're like protruding, there's tightness, then your eye. I mean, are you just talking about like trying to maintain your eyes like more down or forwards versus looking up, which would
There's
be
a party
naturally
trick.
tilted
There's a
there?
party trick you can do. And if anybody on the discussion board knows it and wants to put it in there, please feel free to bail him out of this.
Patrick, bail me out.
What would inhibit some of this suboccipital muscle tone, craniovertebral extensors?
Paul, I actually just texted you to try and bail you out. You can look down.
I was on it. Yeah. Like just, I mean, like bring your chin back and looking down.
Yeah, and it's with the eyes. And why would the eyes inhibit those muscles? And it's called, and this we'll go focus on the suboccipital muscles.
Why would the eyes? I mean, just like if your eyes are up, that tilts your head upwards versus when you're down, it's nodding your chin down.
Yeah, which muscles in the body have the highest density of muscle spindles? No
Maybe eye
input.
muscles.
Yeah, no, the suboccipital muscles.
Oh,
They're think about how fast they need to move with the eyes and the head when you have your suboccipital muscles. So they have the densest innervation because of the speed at which, quality at which they need to move. So one of the things you can often palpate is if you're palpating suboccipitals is you can have somebody look down, and then if I'm going to adjust, if I'm going to do suboccipital release, I will make sure I can close her eyes and look down, and then I'll do cranial. I'll focus on craniovertebral flexion as a motion more than I will trying to stretch the muscle. I want to say once I do this, if I get craniovertebral flexion, then I'm going to lengthen those muscles. So instead of trying to pull or dig into the muscle per se, I will focus on that motion and having them look down with their eyes will inhibit them. If you feel them look upward towards you, like if you're sitting at the top of the bed, you're going to feel more resistance as you check the end feel, because those muscles will naturally fire even without motion.
did you say you have them close their eyes when they do it?
I do so they don't overlook. When you
Okay.
close your eyes, you don't try and tilt your head. Because if not, what they'll try and do is they'll try and tilt their head and look down. So sometimes I'll have them close their eyes, just look down with their eyes, and it'll kind of reflexively happen anyway. So I will use that as my technique if I want to get craniovertebral flexion and inhibit muscle tone. And then, my form of suboccipital release is usually a form of craniovertebral mobilization as I do it. So by mobilizing those upper joints into craniovertebral flexion, lengthening those muscles, versus me trying to, with my fingers, do a finger release technique, which again, I probably just get too bored with it to do it successfully. So Paul, since you're doing such a nice job with this,
Yep.
if I was having trouble, if I rotate to the right or I look to the right with my eyes, I'll make it easy. I'm gonna look to my right. I'm gonna look to my right. What is my right rectus capitis inferior oblique doing? Now, mind you, it's going from the spinous process of C2 to transverse process of C1.
So as you look to the right on the right side, it's shortening. On the left side, it's lengthening.
On the right side, if I'm looking to the right,
Your rectus, which muscle again?
the inferior oblique muscle. If it's
In-
contracting on the right side, which direction is it likely turning my head?
Contracts on the right side. Inferior oblique is turning.
I'm messing this document up, Paul. I'm biding time. I give you time. Hard part of this, Paul, it's all like if you're not sitting here with me in front of a bunch of people, it's super obvious. So everyone always feel free to help somebody else out on the board if you can't stand to watch them wiggle. It's going to be a right rotator. So when my eyes look to the right and you palpate the deep neck, and this is a good one to practice over the next month, just put your hands back there, find spinous process of C2, come up at an oblique angle toward the transverse process of C1. If you have them look to the right, you're going to feel a deep firmness or a deep flicker in your fingertip. And that's going to be the firing of that muscle. So again, these muscles fire even with the motion of the eyes. So that's a good palpation one to practice prior to the weekend cohort. Getting there because it's a right rotator. So being familiar and kind of getting reacquainted with some of these muscle groups, the ones that'll be over facilitated, the ones that should be inhibited, it's super helpful. Like when you're thinking about it from an articular to a muscle layer, then back again. Because if you're looking to inhibit muscles, you can start to think about the movement patterns I can use to inhibit muscle tone or facilitate proper muscle tone. But again, as Eric and I talk about, is like we're going to focus a lot on the joints as well, on the joint biomechanics. How do I get these joints to move optimally when they're not? Whether it's a capsular, myofascial, or an articular restriction. Can I clear that first and then I can get this joint to optimally align. And you'll have people like Gwendolyn and Joel, they'll lament that, yeah, in most cervical patients, you can probably go in there and manipulate the cervical spine when it's an articular restriction, and it will clear their problem and they will have less pain, and then they will go on about their business. But the rub may be is that they don't, again, do the proper neuromuscular re-ed to retrain the movement pattern or build endurance in the muscles that may need better endurance. So they have a tendency then to regress backward over a period of months because we're able to get the pain away quickly. So it's good because you're gonna feel like a rock star when you manipulate this joint and your patient's 80-90% better, by the time they come back for that next session. But it is well worth your time and their time if you can get them to hang around for the neuro re-ed portion of it and make sure they can retrain those patterns. And some of the eye exercises and these things are kind of a key thing. And you'll have to control, like, I don't know about you, Eric. Do you control gaze? I'm sure you control head position. And when let's say you're more active people when they're doing lifting, like you're squatting, deadlifting, what do you look for in the cervical spine when they're doing these motions?
Well, I mean, we only have like 25 minutes left, so I don't feel like I should just get into everything. But no, I mean, I'm big on the eye movement stuff. I think there's a lot of eye tracking issues that can cause all kinds of problems in patients. I think that there's issues that can cause, non-traumatic ACL tears because of abnormal co-contractions or poor co-contractions, things of that sort of nature. So I'm real big on the eyes and making sure that they're tracking properly. And especially when I'm dealing with somebody that has a neck issue, you can see the dysfunction when they move their eyes, right? If they're just following your finger with their eyes, you can see the dysfunction because there will be a little flicker, a little saccade that occurs somewhere in the mid-range of motion. It's not like a nystagmus type thing, but you'll just see it kind of jump, right? It's not smooth pursuit like what we should get. And so it's a good little thing that you can use for yourself to say, okay, am I looking at a problem that's on the left or the right here? And you say, okay, I'm going to have them follow my finger, which we probably should be doing anyway, because we should be doing cranial nerve exams just to make sure we have a good baseline. And this is an easy one to do even with a patient laying on their back. But you can see these things flicker and change. So sometimes we'll have them put their eyes into a position where they've had difficulty and then start going through movement patterns in that sort of situation because we know that they've had issues with tracking in those sort of scenarios. Now that will also come along with other tracking issues that we have. I use tennis balls with numbers and letters written on them, and we'll have them throw them against the wall. And what happens is the ball will kind of knuckle as it comes back to you, and so you can see various numbers and letters. And if I'm having them do that, I may say, okay, if we're having issues on the right side, we just have them turn their body, and now their head's this direction, watching it come back to them. So for me, it's all about the tracking, especially in active patients, patients that want to do sports and be dynamic and that sort of stuff. So it's definitely a thing. But like I said, I could talk about this for hours and hours and we wouldn't get back to the stuff we need to talk about. But yeah, it's definitely something I look into.
Yeah, and you'll see how it relies into like the joint position error and how they look at it in the kinesthetic movement of the neck and how that'll throw this off and integrates the eyes. And we can bump that out into I bump that into a separate exercise section, which would be nice for this.
Yeah.
So we have craniovertebral joints. Biggest movements we're going to look at are flexion extension. We'll wait probably to the course to get into lateral flexion and the other motions because these are small kind of coupled motions. And during the course, we will use these coupled motions to evaluate end range mechanics, but then also kind of treat these end range motions. So we're going to use a lateral flexion to look at, each individual AO joint. But I want you to hear to have a complete set of notes on it. Rotation as well, rotation, being debatable, but mostly kind of coupled within motion. So there's a bit of a rotary motion that can occur, and it's kind of described in here, but we're not going to get into great detail because that would definitely kind of roll us right into the weeds with this. And it's better to be able to have a head in your hands and be able to feel those. Again, I thought it'd be interesting to make a list of, okay, what are the most common causes of restriction at the AO joint? And, you think about this as you go through it. Okay, muscular tightness is the one that we're very familiar with, probably the most research that we get given to us and put out there. Capsular restrictions, probably I would put that up there as well as being one of the things. I think you often find fibrotic restrictions from these prolonged positions. That person has been in that position for a sustained period of time where they've had a chronic forward head posture, that they will lack the ability to get into craniovertebral flexion, and it'll be restricted. This is one that, commonly you're going to find you're mobilizing. And I will use, different graded mobilizations. A lot of them will be like our assessments to get into those joints. Osteoarthritis, degenerative changes, I think you see less maybe here than you're typically going to find it in the lower cervical spine. In this region, you'll see C1, C2. You'll definitely see C2, C3 because of its weight-bearing structure as being the one you'll see. What OA degenerative changes you do see, but it's probably not as pronounced as what I see or as early as what I see in the lower cervical spine. Injuries with this with car accidents, your soft tissue inflation, muscle guarding, joint, if you're having a joint hypermobility at this point, then you're also looking at, basically ligamentous stability at this. And again, you're going to find that though we kind of go to the transverse ligament and the sharp purser pretty quickly, and it's probably one of the most serious ones we'll look at. It's certainly not the most common one. We can talk about that more at injuries that you're going to see in the upper neck. Alar ligament dysfunctions as well. These control, and as we talk about rotation of the neck, the tightening of the alar ligament is going to dictate some of the rotary moments that we're going to feel at C1, C2, and in the neck. So alar ligament dysfunctions and tears, I don't see it often. Maybe every 2 or 3 years, I'm going to bump into an alar ligament tear that's not been found before, or seen in somebody with cervigenic headaches or upper cervical problems. And it can be a driver. I bumped into it in a course one time out there in Chicago. And after the course, because everyone could feel it, and the girl was really nice and she let everyone feel it. But I spent the next hour after that class trying to down ramp all her sympathetic wind up from it. She was kind of a mess. So if we find somebody with an alar ligament that's lax, then two people get to feel it a session for the next 8 weeks or 8 sessions. But we all won't go and feel it because I don't feel like spending the hour after class and winding somebody. Not that I don't mind it. It's just, you don't want that happening. So a good thing to know, because when you see that, you know that it's a little bit different animal. Alar ligament strains, Eric.
Yeah, they happen. I mean, the ones that are I think more common that I run into are ones that have been like, it's like a sprain of the ligament, right? From a MVA,
Yeah.
something like that. And usually these people have seen another therapist or other physicians or osteopaths or chiropractors or whatever, and they're dealing with these headaches and they don't know where they're coming from. People are just poking around and, trying to do manipulations, and they're trying to do needling, and they're trying to do exercise. And, you kind of get in, you just do the stress test, and all of a sudden, bang, bang, there's the reproduction of their pain. And it's just like, well, here's the reason that we're not getting results with these things is because this is an alar ligament issue, and the tissue just needs time to heal, right? So we need to make sure we normalize the mechanics, we improve the stability, improve the coordination, all that sort of stuff. And most of the time, if it's still getting a good, decent end feel, it's not insufficient at that point, then it'll heal up just fine, just like any other tissue. But we just need to let them know that it's not going to kill them, right? And that's just one of those things people tend to freak out about, because if you keep straining it, you keep irritating it, it'll continue to be problematic.
Yeah, I put a few video demonstrations. Like there's some video demonstrations up there just from Jim, just going over a couple course videos, which were nice. So I put some videos in there. They're good to look at now. Many times those videos are really helpful after a course to refresh your memory because you have context. But they're also good sometimes. You're curious, you want to kind of hear a different talk about it and just how to palpate these. That's a nice video to have in there. But again, many times those videos, they're good. Many times they're almost more valuable after a course. But I know a lot of people like to look at them beforehand, which is completely fine. That
It's just good to hear things more than once.
Yeah.
Be able to hear things more than once.
So C1, C2 of the axial joint. Here we're looking at a rotary joint. Anywhere from 45% I've seen it to 50% of total cervical rotation here. And this joint is unique in its design. So it's, we don't assess this one the same way we assess all the other mid-cervical joints. So when we kind of spend our time in lab, we're going to spend a lot more time on occiput C1, C2, C2, C3. And then once we get into the mid-cervical spine, as we look at those joints, they will be unique in just the facet joint length and angles, but there's a lot less variation in what we're looking at, and we'll look at them more grossly the same. Again, primary motion, as you'll see, is like that 45 to 50 is generally the category of range that you're looking at and doing it. So when we're looking at motion, we're looking at nose. So your classic exercise for this is going to be, your nose, your craniovertebral flexion, occiput C1, these motions as we look at it. Secondary motions, we'll talk about flexion extension. They talk about 10 degrees, but with that one, there's got to be a tilting, which is a small degree of motion. And, just because of the shape of these joints, that minimal lateral flexion, if you do get lateral flexion, it's usually probably a coupled rotation motion that has to happen. And this is due to the shape of the facet joints. I guess in clinic, what we're taught most frequently out of the gate is the flexion rotation test, where you flex the neck up, to full end range flexion and then assess rotation, which is good. And you'll find that it's a good screening tool, because it says locking out the lower joints. Some studies have really shown that it does lock the lower joints out, but I often feel like, even as I do this, I still need to discriminate, is it left or right? Like if I go into craniovertebral flexion and I go right rotation, C1 is going posterior, C on the right, and anterior on the left. But then I think also there's a contribution from C2, C3, as this allows a bit of more rotation than the lower joints. So I need to be able to kind of then, once I get a positive flexion rotation test, I'm like, it's my C1, C2. I still need to look at C2, C3. Because many times I'll find this is a C2, C3 restriction, unless it's happening early. Like, do you still do flexion rotation test, Eric, or do you just go right into your biomechanical?
I haven't used it consistently in a while. I do a combined motion test, which I think is it's a little more specific. So basically what this is the C1, C2, the AA joint, because of the orientation of the lateral condyles, and then also because of the contribution of the dens itself, right? So the middle AA joint there, that joint between the atlas ring and the front of the dens, it doesn't allow a lot of forward flexion or extension, right? And it's right kind of very similar to the U joints where it's on the axis of movement. So if I flex my head here and I do a rotation test, so I'm just doing craniovertebral flexion with that, right? Just tucking my chin and trying to rotate. If I have a significant change in the amount of excursion that I have with rotation, with flexion or extension, then I know that the issue is most likely coming from the OA joint, versus if I do that and the motion restriction remains pretty much the same, then I'm going to be comfortable with the idea that the restriction's coming from the AA joint, right? So I can use those two positions consistently, but I don't do a full flexion issue or full flexion position. And the reason I don't is just because of the nuchal ligament, because the nuchal ligament's going to go across all the CV joints. And so we're going to end up with some limitation there one way or the other. And I think that's part of the equation there, is that, okay, this is what's actually locking up, quote unquote, the mid to lower cervical spine, is the tension on the nuchal ligament, as opposed to it being the joints, the articular structure themselves are locked up. Because realistically, the closed pack position of any facet joint is going to be full extension. It's going to be a full extension quadrant position. So into one side motion. But the nuchal ligament will do a very similar thing to it. So I haven't used it consistently, but I do a combined motion test, which is relatively similar.
See if I got a better diagram of it here. Not so much. Here we got a good image of, certainly the dens in the middle, which is going to be that rotation or pivot axis. But, really what I want to talk about too is just the articular facets of C1 on C2 and the lateral joints, because, they are unique. It's not a flat joint. It's described, or kind of what it is. It's a convex joint on a convex joint. It's one ball kind of balanced on top of another ball. And here's my weak balls, but it's kind of like this, as we're going to see it. So it's a sloping motion. That ball is usually made by the cartilage surface of that joint. So you see an X-ray, it looks relatively flat, but the cartilage surface creates that round or domed shape on the superior joint and the inferior joint. And so many times what happens is, we'll talk about during the course, is that, we have these one joint is rolling down either the posterior slope or the anterior slope of the opposite joint. So let's say in this image here, say, hey, we have right rotation. So it's easy to take your head to the right. What I want to think about as I go take my head to the right, that C1 on the right is going relative posterior on C2. And then on my left-hand side, the left joint is going to go anterior and down. So there's a rotation moment that happens. But when we assess these joint collides, we're going to be assessing on the right-hand side, C1's ability to go posterior on C2 and C1 on the right, and its ability to go anterior on the left as these two joints collide. And there's also a downward vector in the slope because it's colliding down a domed surface. So when it goes anterior, there's going to be a down motion that occurs. When it goes posterior, there'll be a down motion that occurs. These motions are influenced, by multiple things, the joint shapes. The alar ligament comes into play. The contralateral alar ligament will come into play with this as it tightens out, and it'll create some of the pivot motion that occurs around it as well. And you'll see that many times in your testing of the alar ligament. As we get into that, we'll look at that and the alar ligament's influence, and also these surrounding tissues. So as we look at that, with this upper motion here is, our craniovertebral motion. So whenever I watch somebody move like this, I start to think of joint motions. I got C1 on C2, C1 on the right needs to go posterior, and then I extend down into C2, C3. So I get in the habit of thinking about looking at these upper cervical motion, talking yourself through it, which one is, okay, C1 is going posterior on the right, anterior on the left. We'll add, during the class, we'll talk about, and you'll see in some of the videos, if you jump to the videos, they'll talk about just, there's different things. When I go this way, the joints are coupled in that direction. If I start it with lateral side bending, and I go into rotation, it's a different rotation moment. To do that on Zoom would be incredibly painful. So for right now, I want you to kind of focus on those rotations. The rest of these motions here just talk about some of the published motions that occur as we get down into the other joints. So this is from the manual, and we'll go over all this there because this will take us down from going from C1, C2 all the way through the other joints. Yeah, flexion extension. It's a slight anterior tilt, very small amount of motion. Same with extension. We have the dens, and we have the dens with the transverse ligament. It's stabilizing structures. Holding this in place. So very limited motion. I don't think of this joint and think of flexion and extension. Do you, Eric? Unless I'm thinking that they're really buggered up and in bad shape.
Not in flexion extension.
No. That is the test when you're doing like your transverse ligament test, is to see is this joint unstable and then able to move too far. So it's a translation test. So if we're getting active flexion and extension at this joint, then you probably have a fractured dens, which is probably the most common one. And then you're looking at your transverse ligament.
And the tectoral membrane.
All of which are damaged in car accidents. I think the tectoral membrane was the one they found was damaged the most, which was interesting. If you're reading, I was reading some of the articles on that. I think it's linked in here too somewhere.
Yeah, well, it's the most posterior, right? So it's going to have the most torque on it.
Yeah,
it's inside the canal, right? So it's basically a continuation of the posterior longitudinal ligament is all it ends up being, but it overlies. If you're looking at this is a cross section here. It overlies the backside of the dens as it's up against the front of the atlas ring, right? So when we go forward, what should happen is the atlas ring starts to tilt forward, the dens would tilt backward into the canal. The tectoral membrane overlies that, right? It sits over the top of that, so that we have the transverse ligament more deep up against the bone, but then the tectoral membrane goes vertically over the top of that, so we can have tearing of the tectoral membrane that will actually allow the dens to tilt further backwards. But it also requires either damage to that transverse ligament or potentially to the bone of the dens, which is more common than damaging the transverse ligament.
Yeah, the dens usually is less stable. Dens usually fracture well before the ligament. Usually your ligament damage, you're thinking somebody maybe has a systemic arthropathy or predisposing, collagen disorder.
Yep. Or they don't have an adequate dens to begin with.
Mhm.
Hypodensia or microdensia or adensia. Those are all genetic variations that do occur. In fact, kids under the age of 12 don't have a dens that's fully formed anyway.
Yeah. Here again, just don't need to go over them. We have the list of the muscle patterns that we're going to see. That, you know, what are going to be the primary rotators that we're going to see. So you can see your deep rotators, you know, contralateral rotators. So it just gives you a sense of, you know, the muscle pattern. Just think so you'll see in here many times. Here's your hypertonic muscles that are incurred with a lot of these problems. You know, you're going to see a lot of this too. If somebody, you know, C1, C2 is a really easy joint to correct lower rotations. And so you're going to find C1, C2 rotations correcting mid, lower cervical, thoracic rotations. Even sometimes you can get as far down into the pelvis. In some cases, if you really want to stretch it, potentially the foot. But likely you're going to correct it much closer than that location. But anybody who's going to have a bit of a rotary component and get in the thoracic spine, it'll be a ring shift or something else. You will see that C1, C2 can be one of the drivers in the being hypertonic, your chronic headaches, your neck pain or referred pain into the skull, because this joint is a really easy one to correct. Like I'm still going to look at you, but if I'm turned to my left, you know, my CB joint is naturally going to make easy correction back to the right. And we're going to bump into this a fair amount as we look at individuals. Let's see. So sometimes you'll also see the influence of this as you get into modules 7 or 8 on the scapula, because of the attachment of the levator and the other muscle tone in these rotations, that you can change scapular position by basically correcting C1, C2. Getting it to sticks a little harder, but you can correct these rotations and these muscle bounces. So it's important to start kind of becoming familiar with these muscles, kind of what they are, how they influence these joints. And again, it kind of helps also direct your muscle work, whether it's going to be dry needling, soft tissue release, contract, relax, or optimal alignment. How do I get my upper trap not to be lengthened with a facilitated levator scapulae? So start to kind of slowly work on these muscles. It's, you know, this isn't to make you feel like, oh my God, I can't remember all this stuff, or it's been so long since I reviewed it. This isn't so much to stress you out as to kind of really introduce these concepts, because we have a lot of time to work together to get these down. So though this is like a, you know, a fire hose of information right now, the expectation is that you're going to pass a final exam tomorrow on all this. And after a while, this will just barely become second nature.
We
Again,
hope.
some common conditions, we'll think, okay, top 5, and top 5 is always debatable. Cervogenic headaches, C1, C2 dysfunctions, you know, and certainly your referred pain patterns. You know, this can be from facet irritation or tight muscles, you know, and certainly, you know, you can talk about, you know, the neural compression that can occur in the greater or lesser occipital nerves. Upper cervical instabilities, you know, if you think about true instabilities, we're looking at ligamentous laxity, and there you're looking at your Ehlers-Danlos, your rheumatoid arthritis. You know, there can be weakening of the transverse ligament. As I said, Eric and I are probably seen as probably bumping into alar ligaments because it's probably an easier one to find, and I often see with somebody who's had a car accident or maybe a sports-related concussion. It's an upper cervical, you know, ligament strain. You know, axial joint dysfunctions, you know, hypomobilities, arthritis, you know, that may be pretty high up on the list, probably well above what I'm going to put at number 2, which would be craniovertebral instabilities, because I certainly see 3 more than I see 2. And again, alar ligament strains, as I said, you know, I'm seeing these and I find them. It is not something I find in everybody or frequently, but I definitely want to know if I have it, because it definitely sets my expectations. I really kind of know the picture of what I'm looking at now if I can find this. So this is important for me to you know, make sure that it's not there as much as to make sure that it is there. Whiplash associated disorders can be varied from, you get overstretching and damaging of soft tissue structures. You know, the most common thing there is going to be, you know, facet joint irritations, tears in the capsule, you know, articular problems. And then much like in the lumbar spine, we're going to run into inhibition of multifidi and changing of neural recruitment patterns. So probably number 1 thing you find there is going to be that. you know, with whiplash associated disorder, vascular could probably be in that conversation too at some point, and we're going to talk about that in a later kind of Zoom session as far as safety. But you know, with the whiplash associated disorder, really there's a lot of different areas that can be damaged. But primary, the facet joints is the number one thing they see, and it has a lot of muscle balance implications. Things that don't require surgery is basically your instabilities, your Dens fractures, and your axial subluxations. And that's going to be weakness of the transverse ligament and the integrity of that segment. Good. And the rest was just bonus stuff. I know this is kind of dense, just getting into this, but it's an important thing to really introduce now, because what I want you doing, and you can email us if you have questions or you need help with this, or want a video on, hey, how do I go and do this in clinic, other than one that I provided from Jim, but to start feeling these motions now and getting a sense of them so that it's all not kind of new when you show up on the weekend. To kind of start to think about, okay, let me think about the motion here at these upper craniovertebral joints. Can I start to get a feel for it? Can I start to kind of get a kinesthetic awareness? That way your learning curve when it comes, you know, Saturday morning will be much greater, because then it's me refining a few things that you've already been practicing. I want you to play with the eyes a little bit. Have them look up, have them look down, or have them look to the left and right, and just feel how it changes the tone in there. Especially if you're doing any kind of suboccipital release, play with the eyes a little bit. Do it with your exercises. You know, as you're doing it, think about how the eyes are. If I want to have somebody back in here and I want the chin tuck, you know, there. If you want the chin tuck, I also want you to think about, again, what we talked about is basically neutral lumbar spine. How do I set my deep system in my pelvis? Because I need that to happen first many times before I think about getting myself into a craniovertebral neutral position. Because if I'm slouched forward and pushed forward, then there's no amount of chin tuck, which is going to bring me back to neutral. So yeah, any confusion with this, you want a little help or you want a little clinic tidbits, please hit the discussion board, hit me up, hit Eric up. I'd be happy to kind of get you some things to kind of help get you practicing and feeling these regions and kind of working through this. You know, this is take these notes. If there's anything in these notes that you're not sure about, great time to just go, nowadays you can go online, look it up, PubMed, Wikipedia, Physiopedia, get a little deeper depth, a little deeper dive. That is it in a nutshell for today. Whoa, 1 second here. Let me bring the screen back up.